Yes, perfect. Everything is set up. So today we are going to talk about FSGS, or focal segmental glomerulosclerosis, like a big terminology, focal segmental glomerulosclerosis. In short, FSGS. FSGS is a clinical pathologic entity, okay? By that, I mean, it has to have some clinical features. So proteinuria is the most important clinical feature. Variable amount of proteinuria. It can be a complete nephrotic syndrome. It can be nephrotic range proteinuria, or it can be subnephrotic proteinuria. And that is a key. And it is very important whenever you are dealing with a patient of FSGS to understand what is the extent of proteinuria. And specifically what I have seen, sometimes there is a confusion between nephrotic syndrome and nephrotic range proteinuria. Both are not the same in context of FSGS. So clinically, you differentiate what is the presentation and what is the extent of proteinuria, and then you biopsy. On a biopsy, I will start with focal. What does that mean? In this field, you are seeing a ton of gloms, so many number of gloms. If a disease involves only few gloms, we are going to call that as focal. So that is what it means, focal in FSGS. That means only few gloms are going to get affected by focal segmental. That means only a part of the glom. So out of so many number of gloms, only few of them are going to show us the disease. Like in this field, I'm seeing many number of gloms, 1, 2, 3, 4, 5, 6, 7, 8, and 9. Only one of them is showing something which has not been shown by the others. Like in this power, let me go on one more high power. So over here, I can see a glomerulus.
It's a little bit blurry for us.
Okay.
I think maybe it needs to be focused just a bit.
Yeah.
Yeah, that's better. Now? Yep.
Yeah. So basically, focal, only few gloms, and segmental. So within a glomerulus, if a disease involves only a part of the glomerulus, we call that as a segmental. So in this one, this part of the tuft does not look like others. So what is happening here? So basically, in the last session, we went over the normal histology. Over here, what I'm seeing, the tuft is obliterated by something which is pink, like a pink matrix material. The capillary loops are not open, and there are some cells which are stuck within this sclerotic area, and there are some cells which are outside. Let's call it sclerosis. That is it. Sclerosis means scarring. When the scarring is present within the tubular interstitial compartment, we call that as a tubular atrophy and interstitial fibrosis. When scarring is present within a glomerulus, we call that as a sclerosis, and it is involving only a part of the tuft. That's why we call it as a segmental. So basically,
Shree, can you tell us which stain we're looking at and kind of how we should? And how do you know that it's a PAS and not a H&E stain?
Okay, because it is more pink. In the last session, we discussed that PAS is going to be more pink. So I have to show you H&E stain to compare, like what is more pink as compared to a. So this is a PAS stain. So the extent of pinkness is different. This is used generally for general architecture. So in this one, you can see the glomerulus, but it is the architecture of the glom is not seen very nicely on a.
So this is the H&E stain, correct?
Yeah, this is the H&E stain. You can see the gloms, but the basement membrane, the matrix is not visible. So today for the FSGS, most of the time I'll be using PAS stain. Okay.
And also on the PAS, sometimes the tubular basement membrane is a bit more apparent. Is that correct?
Yes, because that basement membrane, anything which will have basement membrane, like the TBM, this is basement membrane, the GBM, which is basement membrane, are going to be highlighted with the PAS as well as silver. But PAS is good because it is a good screening for us for FSGS. So today, most of the time, I will be using PAS, but in between, I'll also show you the lesions on silver as well as the trichrome stain, if it is relevant, yeah. So we went over the definition of, or the morphological features of FSGS. That means,
Shree, sorry, we're nephrologists and we're trying to And this is amazing to see this. And I want to just sort of clarify a few things. And
sure.
Maybe this is, very simple, but if you go into that glomerulus and the one that has that focal lesion, you have the dark pink part, and then you have the cells that are kind of coalescing together.
Sure.
Do you have to have both of them or just one? Or is it the combination of the two that makes it a sclerotic lesion, or what's it? Can you explain that a little bit?
Yeah, definitely. So what you're asking me, like, how do you know this is sclerosis and what is constituting sclerosis? Okay. So let me start with the story. Sclerosis is not going to have only this morphology. It will have variable morphology depending on the type of lesions you are seeing. So what makes this as a sclerosis is the obliteration of the tuft. Over here, I can see the capillary loop, I can see the mesangium, I can see the mesangial cells. They are nicely organized, and they
so it doesn't really matter what's in there as long as the capillary tuft is obliterated.
That is the start. It does matter what is in there, because I will go gradually and I'll show you different morphological variants. So depending on that, it will matter what is there, but not exactly. Obliteration of the tuft, you can say, is sclerosis. That is the start.
Ganesh Srivasa has an interesting question. And at this point, can you differentiate this between nodular sclerosis of diabetes or another entity?
Yeah, definitely.
You can.
So whenever you look at a gland, you don't not only look at the lesional gland, you look at the background gland. Like in this one, we went over the basic morphology in the background. The other glands in the background are absolutely normal. If it was a diabetes, other glands in the background will be affected, right? Because it is a diffuse lesion. In this one, all the other glands in the background were absolutely normal. Like on this one, it was absolutely normal, right? But I ended up seeing lesion only in this gland. So that's why, like, it is not diabetes. And I can understand why he thinks this can be a nodular one. So again, so let's focus specifically on this gland. Nodular mesangial sclerosis, that means the lesion has to be mesangial based. Like if this was going to get converted into a nodular sclerosis, this area will expand gradually and will make it as a nodule. In contrast, in this one, what is happening? The segment or the part of the glomerulus is sclerotic. It is obliterating. This architecture is not because of the expansion of the matrix. This architecture is because of the destruction of the tuft, and that part of the tuft is undergoing scarring. So the pathogenesis behind this morphology is different. So, and you can easily differentiate by looking at the other glands in the background, as well as going deep into the morphology of this gland.
Thank you. I think that's perfect explanation.
Okay. So when we understand morphology of a lesion, as you said, there are some pink material, which we are calling it as a matrix. There are some cells. So how I should explore more about that morphology, right? So that is one way I can see as I go forward and explore different lesions. What is the extent of this pink material? What are the cells where actually this adhesion is present? Right now, I'm not sure. So when you look at the gland, there are two things, right? So location in a gland, there is a vascular pole from where the blood is entering into the gland, and there is a tubular pole. So those are the two directions directional morphology of a gland. I have a hilar pole and I have a tubular pole. I will keep that in mind when I will go forward. Okay. So if a lesion,
can you show us the hilar pole and the tubular pole?
This is the hilar pole because it is the place where the blood vessels are going to enter into the gland. This is the hilar pole, and this is the tubular pole. See, the tubule is getting continued over here along with the Bowman's capsules. The parietal epithelial cells are getting
can you keep that there for a second? I need to take a picture of that. That's absolutely gorgeous.
Yeah.
Okay.
And I will tell you the importance later on.
You can go
so
now.
Matt, you pointed out the morphology of this lesion. So constituent of that lesion is important, matrix and the cells. The other thing which will be important subsequently, what is the location? Where is that lesion present? So I will use these two locations, okay? I will use this hilar area or hilar pole, and I will use this location, not right now, okay? Subsequently. So on morphology, on light microscopy, when I'm dealing with an FSGS, I look at the gloms, and I look at the morphology of that segmental sclerosis. For now, remember this morphology. Other things I will discuss later on. And then we look at the tubulointerstitial compartment. We are not going to deal a lot today about the tubulointerstitial morphology. We will deal in subsequent sessions. But in this case, there is background tubular injury, and there is subinterstitial inflammation and vascular disease, okay?
Shree, what was that clump of cells that was kind of right next to that sclerosed area?
Right here, they were all lymphoid cells. So over here, yeah. So the background is pink.
No, within the glomerulus. Are those podocytes, or what are those?
Yes. So they over here they are like the epithelial cells, which are proliferating in reaction to the sclerosis. Yes.
Right, because in FSGS we know that we have hypertrophied podocytes, and
yes.
Usually in other disease processes we can't even see the podocytes on light microscopy.
Yeah. So you are having hyperplasia and hypertrophy of the epithelial cells, which are lying over the tuft. So on light microscopy, we appreciated the lesion. Okay, I have segmental sclerosis present. The next thing which I'm going to answer, or next question which comes to my mind, who is driving it? Why I am seeing those lesions of segmental sclerosis, right? So as a kidney pathologist, we have few things, right, which we can use. The one thing is immunofluorescence. In FSGS, IF is negative. I should not see any deposits on immunofluorescence. So this is a negative IF. That means this is the glomerulus, which we saw in light microscopy. In IF also you see the glomerulus. The tuft is completely negative. This green thing, which is more green as compared to the background, are the protein droplets, which are staining non-specifically, okay? In FSGS, you can see the segmentally sclerotic lesion on IF, but the tuft is completely negative. And depending on different kind of types of FSGS or morphological variants of FSGS, you can see the lesion in different areas of the glom, but you don't see any staining within the tuft, but you see staining only within the podocyte protein droplets. So even on the immunofluorescence, you will know that you are dealing with FSGS. I'm not seeing any staining. Sometimes non-specific staining you can see with IgM, C3 in the sclerotic tuft, but most of the time your droplets are going to stain non-specifically.
Can I ask you a question about that? Is this more common in patients with a lot of proteinuria?
Yes, you will see
non-specific staining that occurs from protein droplets. Is that what this is?
Yes, you will see in a lot of proteinuria, but with segmental sclerosis, you will end up seeing droplets. Otherwise, in a lot of proteinuria, you will see those droplets within the tubules, not within the glom.
Got it, not within the glom.
Mm-hmm.
There's a question from Sanjit Roy. If the immunofluorescence shows protein reabsorption droplets, does that suggest collapse?
Not always. Any lesion of segmental sclerosis can show you that. Collapse just has a ton of protein droplets. So you will be able to see that very easily in a collapsing lesion as compared to the other variants. I will show you all the variants and I'll explain you the rationality behind it. So IF in all the cases of FSGS is going to be negative, okay? So now you move on to EM. So what do you see in EM? We already know that I'm not going to expect any deposits, okay? But I'll confirm that on EM. Whenever we look at an image of EM, we orient ourselves, okay? There will be a mesangium. There's going to be a capillary loop. And there are red blood cells. That's why I know I'm within a capillary loop. There is GBM or glomerular basement membrane. And outside the GBM, I'm seeing podocytes. See those processes which are standing on its own? So those are the normal foot processes, okay? Those are the normal foot processes. Focally, you might not end up seeing those processes standing. Like over here, you cannot see them. They are almost like flattened. They are effaced over here. In contrast, you can see the processes standing over here. This is normal. When you end up seeing those foot processes standing like the row of pillars, that is normal. Effacement is abnormal, okay? I already know I am not expecting deposits, so I'm not going over deposits right now. And in this case, there are no deposits. See this pillar? They are standing, foot processes are standing independently on their own. That is normal.
Wow, I've never seen them look so nice.
They are like just really
Yeah,
tall.
row of pillars standing. This is normal, okay?
They look like like those sea anemones with the little fingers.
It does. Like I need to see Nemo in there.
Jumping around, yeah.
This is that abnormally looking like
this one?
Nice, like too nice?
No, normal foot processes will be standing. So if you don't see standing foot processes, that is abnormal. So this is a low power image of EM, and you can see multiple glomerular part, like the loops, and I just cannot see them. See, all of them are flattened. This is effacement, okay? This is effacement of the podocytes.
So I have a question from Panu Mishra. How do you decide if you're going to describe the effacement as focal or diffuse?
Yeah, I'll come to that, okay? So in this case, I cannot see the processes as they were standing, like this was normal. In this case, this is abnormal. So we will take one thing at a time. Okay, I decided this is abnormal, okay, because it is showing me effacement. Effacement of podocytes. That means something is going wrong with the podocytes, and the terminology which we use is podocytopathy. That means podocytes are abnormal. They are showing you pathy, cytopathy, abnormality of podocytes. That's why FSGS is a podocytopathy. It is an abnormality of podocytes. So what is happening? What you ended up seeing on light microscopy is actually the abnormality of the podocytes. So if I have to make a story in my mind, what might have gone wrong, man? What might have gone wrong with this podocytes? So let me tell you a story. What might have been happening, those podocytes which were lining the outside of the GBM or lining the capillary loop might have been damaged because of variable number of reasons, okay? So when that happens, the GBM is deprived of the external cover. So this area will be bare. It won't be without the podocytes. Now it will try to heal itself. What does body does? Any damage, if you end up getting a wound, it will heal itself by scarring. So what will happen? The glomerular tuft is going to get adhered to the Bowman's capsule because it's trying to heal itself. So the podocyte or the glomerular tuft immediately will get adhered to the Bowman's capsule. And now the repair process or the damage process will continue. You will see bunch of proliferation around. What will happen? Only a part of this tuft was damaged. The neighboring part still might be functioning. So the plasma protein will keep on exuding, right? So the matrix will have hyaline material. There will be foam cells which will come to take care of that process. We will go over that morphology later on, but that is exactly what is happening. We are damaging the podocytes. That's why this is a podocytopathy. FSGS is a podocytopathy. In your board exams, most of the time, you get a simplified image. If you end up getting a bigger image, you will be confused. Where should I look? Hey man, what is this nuclei? What is that cell? What is that? So to simplify the life, most of the time in exams, you end up getting a very simple image. So basically the pathologist is asking you to focus right here, okay? But when you start your fellowship as a first year, you look at that, and gradually as you learn, you know, these are all nuclei, this is a red blood cell, this is all surrounded by a glomerular basement membrane, and I don't see the normal foot processes, they're not standing, they are all effaced. So you are dealing with a podocytopathy, and now you know the name of that disease because clinically, your patient had proteinuria. On light microscopy, you ended up seeing segmental sclerosis. Your IF was negative, and on EM, you saw foot process effacement. That's why this is a podocytopathy. Any questions so far?
Yeah, so these nuclei here, these are both endothelial cell nuclei, correct?
This will be an endothelial, most like this is an endothelial cell. This can be a mesangial cell because you are very close to that mesangium. So these are mesangial cells, and this is an endothelial lumen, capillary lumen. And these are the endothelial cell fenestrations. This over here, you can see those fenestrations, the gap in between that. And these are the red cells over here.
Quick question about this. This is an EM, very, close-up view. And that in the glomeruli, though, some of the gloms look normal, and then some don't. Do you have this podocytopathy typically happening all over, and but you only see the segmental lesions in certain areas? Sure. Can you comment on that?
So yeah, definitely. So basically, you are asking me a question. What is happening? Are the podocytes getting damaged throughout the kidney, like all the gloms or millions, all the million of the gloms are involved, or only few, like on the light microscopy, we saw only 1 or 2 gloms getting damaged? So Matt is asking me that question because depending on the answer, he is going to treat the patient. Suppose if the podocytes are involving all the gloms in the kidney, it will be a diffuse podocytopathy, okay? We call that as primary FSGS, okay? If only a few gloms are getting affected, okay? It is not 100%. There are many exceptions to that.
And but when you say affected, are you saying on light microscopy or
on light microscopy? But okay, what you are seeing, the abnormality might be involving the few gloms on the light microscopy. But the disease, whether it is involving all the gloms or not, it depends on whether this is a primary FSGS or a secondary FSGS. And that is the segue of classifying, right? And that is the point of classifying FSGS, because we want to know who is the driver of that podocytopathy, and is it involving all the gloms or only few of the gloms, right? So that's why so many definitions, I think that confuses fellows a lot. So if you look at the classification system of FSGS, primary and secondary classification, we divide FSGS into primary FSGS and secondary FSGS. That is one way of classifying. Many people will say, let's classify on the basis of nephrotic syndrome or non-nephrotic syndrome FSGS, because for treatment, that is what is important for me. Many people will say, we should classify FSGS on the basis of pathogenesis. Who is driving that FSGS? Is it permeability factor? Because then it is going to involve all the gloms within the biopsy. Is it adaptive? Then it is going to involve only the few gloms. Then that is one way of classifying. The other way of classifying is on the basis of pathology. And that, like the Columbia classification, which came out in 2004, right? Tip variant, collapsing variant, cellular variant, perihilar variant, or NOS variant. Basically, all those classifications scheme are trying to answer, are the podocytes involved throughout the glom or only the few glom? So the answer, Matt, is it depends. It depends on the type of FSGS, the clinical presentation of FSGS, but that question is very important for us to answer, because that question is going to dictate how you are going to treat your patient. Okay.
Okay, so another question in that same vein, what about an individual that has a genetic mutation? Is there any clue to when you might want to send a genetic test, or is it as a familial, sort of if multiple members of your family are affected, or tell anything based on the biopsy that might suggest to do that?
Yeah, again, it is a clinical pathological. So clinically, young age is very important. More young your patient is, chances of having genetic FSGS is very high. As the age of the patient is going to increase, chances of genetic disease will be low, okay? And as we are identifying more and more genes, we will know more and more genes which are going to cause FSGS. The other clue for you is, as I said, family history is again very important. Therapy-wise, once you made a diagnosis and you start treating your patient, depending on the type of FSGS, if you are not getting a response, then also genetic variant of FSGS should be, we should have to think about genetic variants of FSGS. Morphology-wise, there are no strong indicators. Like there are some, like if there is a collagen abnormality, you will see abnormalities of the GBM. You will see lamellation, you will see basket weaving, you will end up seeing abnormalities of the GBM if there is a collagen mutation. So not specifically, you won't see a lot of hints of genetic mutations on the biopsy, except for few. Okay.
There's a question from Cesar. Can you have large subendothelial hyaline deposits in FSGS? And if you can you explain its importance or significance?
So yes, you can see large subendothelial hyaline deposits in cases of FSGS. The significance is basically your plasma proteins are getting exuded out because see only so this is the example of that.
Is this the same patient from before?
This is a different patient. So because of that question, I ended up picking it up. So
got it. You just, it's like a baseball card collector. He's got everything right next to him.
so this is what you're mentioning, like a lot of hyaline, right? In the subendothelial region. What does it mean? So basically, as I said, initially to start with, only a part of the tuft will be damaged. Only few podocytes.
Can you just show that one more time? What were you saying and point to where it is?
Can you see the arrow?
Yes.
Okay, that is the hyaline he's mentioning. It's a
hyaline.
Hyaline, H-Y-A-L-I-N-E.
And why do you call that hyaline?
Man, what do you call that hyaline?
That's what we're trying to do. We're trying to be very, you know, like, is it because it's pinkish right there? That I mean, for everyone on the call, we want to try to bring it down to the level of a first-year fellow.
I agree with you. Hyaline is this pink amorphous material, almost like a fluid-like. This pink, you can see some structure to it. This is like a fibrosis, like the matrix was.
So one's like a kind of like a lake, like a
lake,
on
almost,
a morning.
Yeah, that's a good
term.
Glassy. It looks like a glassy.
Yes, glassy, lake-like, a puddle. You know, basically
and that's
plasma
hyaline.
proteins.
See, this is that's really important, I think, for people to start talking like a pathologist, so you won't roll your eyes when you hear us talking to you.
I agree with you completely. Look at the morphology and understand it in the terms which you understand. As long as you understand the pathogenesis, you will be able to treat your patients well. You know.
Got it.
Yeah.
And there's a question about this glomeruli, or these two specifically. Are there either hilar or tubular poles here that you can see?
Yeah. So I will go over that. So basically, remember the morphology which I showed you last time. Okay, that was a nondescript FSGS lesion. So I'm showing you another FSGS because we will follow that same reasoning. I see obliteration of the glomerular tuft because over here I can see the intact capillary loops, but in this area I cannot see them. They're completely obliterated. And as I discussed, some of the loops still might be intact and might be filtrating, but it is all scarred. So they will end up getting trapped here. So the hyaline material or pink material, very foam-like. Not foamy macrophages are not here yet, but you see that hyaline material. And then I have to find out the location, because as we discussed last time, location of the lesion is very important. So let's focus on this gland. In this gland, I cannot see the location for sure, right? We discussed there are two locations, hilar pole or tubular pole. And as we know, gland is a three-dimensional structure. So it is possible on every level, on every gland, you might not be able to see that. So in this one, I see a lesion of FSGS. Segmental sclerosis, increased matrix material, adhesion of the glomerular tuft to the Bowman's capsule, entrapped hyaline. So in my next few words, I ended up describing the lesion of FSGS. Then I moved to the next gland. Boom, I know this. What do I know? This round thing with a lot of layer within the wall is the hilar end or the vascular end. And this is also a vessel. So what I'm dealing with is a lesion of segmental sclerosis around the hilar pole. Again, this is not going to be the only gland. Depending on the biopsy, this might be the only gland, but hopefully in this case, we'll look at other glands to see and confirm, am I in the hilar pole? But I can see two blood vessels here, and I can see the lesion of segmental sclerosis. So this will be, according to Columbia classification, a perihilar FSGS.
So I just want to point out to everyone, there's no way I would have told anyone that was a hilar pole unless you showed me.
Okay.
I don't know. I see it now, but
how do you know that that's a blood vessel?
Yeah. So let me show you a classical, hopefully. Yeah.
I was going to call that NOS.
I didn't know what it was.
Can you say this is the hilar pole? This is
the same gland, just cut a little higher.
This is the different gland actually in the same biopsy.
Different gland.
But you can see those hilar pole. Normally we are accustomed of seeing the blood vessel entering on one side of the glomerulus, right?
Mm-hmm.
So this is the hilar pole, and you can see the lesion of segmental sclerosis. Because all the glands on the biopsy are not going to be well oriented. So gradually, as you will start seeing more and more biopsies, you will be able to figure out the morphology, and you can see the three-dimensionality of a gland once you see different sections and all that. So this is the highlight pole, and you can see the segmental sclerotic lesion. So morphology of the segmental sclerosis, once more, obliteration of the glomerular tuft, increased matrix material, entrapped hyaline, and there is adhesion of the glomerular tuft to the Bowman's capsule. Over here, you don't see any adhesion of the glomerular tuft to the Bowman's capsule, while over here, you see that. So this is FSGS. It is lying close to the vascular pole. I'm calling it as a perihilar FSGS, okay? And one more.
Can I also just point out to the group, there are some questions that are being answered by Dr. Alejandro Best, who is also a nephropathologist. So if there are questions that I can't answer or Dr. Farouk can't answer, he's doing that.
Or
so,
if I can't answer, he is going to answer that.
Yeah, so I don't want to,
So, yeah,
we're not giving you everyone. So just to let the viewers know that he is a nephropathologist.
Yeah.
I'm just a wannabe.
What is abnormal with this gland? Man, I was trying to go over FSGS and ended up showing up a gland. I have no clue what this is, right? So what I'm trying to show you is a glomerulus which is not fitting into a field, right? It is a huge gland. Can you see the size of this gland? This is a huge gland. This is a glomerulomegale. That means a huge gland. So when you see a perihilar lesion of FSGS, next question you are asking yourself in the FSGS classification, is it an adaptive form? Is my gland, or is my kidney working too hard to filter? So what are some of the scenarios where a kidney is going to work too hard? If there is a single kidney, oligomeganephronia, if the patient ended up losing kidney for any other reason, or for disease.
What was that word? That sounds like a really good word for Scrabble.
Oligomeganephronia? Yeah. Less number of nephrons? Yeah. Wow. Yeah. So basically you are having less number of functioning units. So if you have less number of functioning units, your remaining or non-scarred functional units are going to work very hard. So when they work very hard, you will end up seeing enlargement of the gland. So this is not 100% right. You can see glomerulomegale in other types of FSGS and other lesions also. But in
is that a 40x objective?
Yeah.
Sorry, Shree, can you go back to that gland for a second? Does that look like a kidney to anybody else?
Kidney?
It really does.
Yeah.
Maybe a brain too.
Right. This looks like a kidney. Yeah, this is beautiful.
It's like a brain inside of a kidney.
Yeah.
Keep that there.
It exactly
I need
like
to get a
that.
picture
now I
of
can
that.
see the kidney. With the hyaline.
Matt, I got the picture.
Oh, you got it. Okay.
Okay. Yeah, this looks like a.
And what are there any criteria that you use to say that this is a large glomerulus? Because obviously it depends kind of what power you're on, right?
Yes.
Or the 40x objective, if it actually fills the entire screen, is what I was always told.
Yeah. Yeah. 40x. Yeah.
Is that right?
Yes, 40x objective, more than 50% of that 40x. And again, 40x, more than 50% of the 40x, it fills up. It is glomerulomegale. Yeah.
But Shree, let's define, because I'm getting conflicting questions on that regard in the chat. So when you look at the field on your screen, on the software that we use, it's different than the field in your microscope. In the microscope, you need to fill at least 50% of the field on your microscope on 40x. When you look at it on the software, and these varies by application, but it's normally, it has to fill the screen. So that's where the discrepancy is at.
Okay. So in this software, you can see that filling up the entire field, which is software dependent. That will be very variable from like which software you use, which one. Yeah. I agree. So this one is filling up the entire field over here. Yeah. And I am at 40x right now on my microscope.
Can you comment on these smudgy appearing cells that are throughout? I don't know how to best describe them. They're kind of light purple and a little bit of those. Yeah. Is that just an artifact, or is that something that's happening?
Okay. So let's have some tools where we can approach the kidney morphology when we are alone, because as a fellow, that is very, very important. Okay. Mm-hmm. So we went over the morphology of the gland. This is the mesangial area, and I'm seeing the loops. So those purple cells, or those cells which are floating around on their own, ideally there should be a location of the visceral epithelial cells, right? Because we know outside the GBM, in the normal scenario, there should be visceral epithelial cells. Okay. We are dealing with podocytopathy. Okay. So that means something is going wrong with the podocytes. So in FSGS, in some variants, what you will end up seeing reactive podocytes. They will end up reacting to it because they're abnormal, right? So you will end up seeing very prominent podocytes. So these are just prominent podocytes in the case of FSGS. And you're not seeing any other proliferation. So they are reactive podocytes, and they are in different plane, right? Different type of cell. That's why they are staining differently. Okay. So this was a perihilar variant of FSGS. So next question will be, what does that mean? So Columbia classification between primary and secondary FSGS. Like this is a silver stain, and I wanted to show you that, and I will explain you the rationality. So for any variant of FSGS, whatever we talk about, the most important clinical question is it a primary FSGS or is it a secondary one? Because your treatment depends on that. In a case of primary FSGS, you are going to give your patient steroids or immunosuppressants. In the secondary FSGS, you are going to go for conservative management, like means you're going to go for ACE-R, weight management, and other things. If there are any other drivers, you will take care of that. But you're not going to do steroids or immunosuppressants in secondary FSGS. Morphological variants, which I'm going through, is not going to help you answer that question. Is it a primary or a secondary? The most important thing which will help you to identify primary or secondary is the clinical presentation. If the clinical presentation is with a nephrotic syndrome, and on biopsy, when you see the food process effacement greater than or equal to 80%, you are dealing with a primary FSGS. If those two scenarios are not met, it can be anything, okay? And most of the time, secondary FSGS will have variable proteinuria, but not invariably nephrotic syndrome. Morphological classification, initially we thought, like many times when we go over the morphological classification, we get confused. Is it a primary or secondary? So morphological classification is not going to help us distinguish that. So the NOS variant, which I showed you initially, the perihilar variant, which I showed you just now, they are just morphological variants. They are not helping us out to distinguish between primary and secondary FSGS. So depending on the clinical presentation, if the patient has nephrotic syndrome or not, or is there a complete or more than 80% food process effacement or not, that is going to help me answer the primary and secondary FSGS question. Morphological variants are important. Some of the morphological features are going to help you to find out certain things. Like in this case, the perihilar variant of FSGS along with glomerulus miguel is telling us that glomerular filtration is under pressure. It's a hyperfiltrating gland. Patient might have obesity, patient might have been born with a low number of nephrons and the other etiologies which we discussed earlier. But it is not helping us really to distinguish between primary and secondary. Similarly, other morphological variants also are not going to help us with that. And let me move over to some other morphological variants of FSGS, okay? Any questions so far?
So many questions, Shree. So many that I can't even get them all out right now.
Is a little confusing, okay? So,
but you're doing great, and this is what we need is just to really dive deep into FSGS, probably once a day for me, but
yeah, it is confusing. And specifically because people approach the same entity from so many angles. But for you as a clinician, you are asking me just one question. Shall I give steroids or immunosuppressives, or shall I go for conservative management? That's it. You're asking me. And then we are going to discuss about prognostic factors and other things. So let me show you another morphology. This is again segmental sclerosis, right? Because it fulfills all the criteria we discussed. There is an obliteration of the glomerular tuft, increased mesangial matrix, and this lesion is touching something, the tubular pole, because this is the tubule. This is not, let me look at the other morphology. This is again beautiful. Lesion of FSGS, the lesion is showing you confluence at the tubular pole, and there is adhesion of the lesion at the tubular pole. So when you see a lesion of segmental sclerosis at the tubular pole, you call that as a tip. Again, reminding, if you see the lesion of segmental sclerosis at the hilar area, that was perihilar, If you see the lesion of segmental sclerosis near the tubular pole or at the tip, this is known as the tip variant. Tip variant of FSGS, right? It is important. Why? Because it is one of the variants of FSGS which has very good prognosis, almost similar to minimal change disease. And your patients, they do present with nephrotic syndrome. So tip variant of FSGS, if I have to make up a clinical history, I can say this is a 30-year-old patient who presents for evaluation of nephrotic syndrome. You end up doing a biopsy, reading the biopsy, see the lesion of segmental sclerosis, and it is adhered to the proximal tubule. This is the tip. And then you know, and when you look at the EM, as I said, this will be a primary variant. So you will see greater than or equal to 80% foot process effacement. And then you will make a diagnosis of either tip variant. If you are looking at a lesion of FSGS, but you cannot establish the relationship of the segmental sclerosis with the tubular pole, you might just end up calling that as a primary FSGS, okay? And as a fellow, during training or while reading books, there are a couple of morphologies you will see, and that gets stuck. We end up assuming that is going to be the morphology on all the cases we see. But even in tip variant, morphologies will be variable depending on the biopsy you see. So I will just show you a couple of examples of tip variant, and you will see the biopsy morphology is highly variable. This is another tip variant, and see, this is totally different looking, but overall the same thing. You're looking at a lesion of segmental sclerosis. And now, to classify this into tip, you want to show the relationship of this lesion to the tubular pole. And as we know, you might not end up seeing that relationship on all the sections or all the levels, but you want to prove that. And this is the hilar pole. This lesion is far away from that. This is at the tubular pole. So you end up looking around the glans and you try to find out where is that relationship. So once you show that relationship, you classify that particular lesion as a tip variant FSGS, okay? Is it making sense?
Yeah, this is great.
Okay, perfect. You wanted to see silver because let me show you a tip variant of FSGS. See, this looks different. And let me find that lesion and I will stop right there. Can you appreciate the lesion of segmental sclerosis right here? And you can see the foam cells. And let me establish the relationship of that lesion to the proximal tubule. Can you see that lesion of segmental sclerosis right here at the tubular pole? Lesion of segmental sclerosis right here at the tubule. So this, you can see the relationship of the lesion to the tubule. That's why you're calling it as a tip variant of FSGS. Very good prognosis. Your patient presents with nephrotic syndrome. Those are the 2 points I will remember about that. And a common question, like the next variant of FSGS, which everyone loves, and this is a favorite exam question also frequently. And I'm going to, in other variants of FSGS, on the low power, morphology was not that different, but in this particular variant of FSGS, low power morphology is again very important. This is a PAS stain. I'm showing you a cortical parenchyma, and in this parenchyma, you can see the tubules, they are dilated. They are showing you some pink material within the tubules, and you can also see some pink granular material within the tubular cytoplasm, okay? You see the glans, but you cannot see focally the architecture of the glans very nicely. The segments are almost obliterated. So let's go on high power to see what's going on. We have not seen this kind of tubules in the previous slides, which we looked at. The tubules are just packed with protein, and a couple of questions initially were popping, like about the proteinuria. So this variant of FSGS, whatever that is showing you a massive amount of proteinuria. You can see the protein droplets within the tubules. The tubules in the background are dilated, almost forming like a microcyst. So there is a microcystic dilatation of the tubules. They are filled up with PAS positive hyaline cast. This is a normal glomerulus, and then boom, this is not normal. In this one, the entire tuft is not looking normal. It is collapsed, it is implosive. collapse of the tuft. Let me find out a good glom. This is again a glomerulus, which is showing you the implosive collapse. You cannot see the tuft on this one. It is completely obliterated, okay? Let me pick up a different stain, like a silver stain, which will again help to identify the morphology in a better way. This is again a good one. In this one, entire glom is collapsed. The tuft is obliterated. A good way for us to imagine is, imagine like a pump which ended up sucking up the entire blood, and the entire capillary loops ended up just collapsing. It ended up imploding. And there is not a lot of proliferation. I will show you some other examples where we have done a proliferation, but there is some proliferation of the overlying visceral epithelial cells along with podocyte protein droplets. Along with this lesion of FSGS, you are seeing a ton of tubular interstitial change, microcystic dilatation, and prominent protein resorption droplets. So let's look at.
So Shree, we have a question from Manisha. You might know her. There's the cast that not the cast, but the protein kind of looks like the fractured cast that we described for myeloma cast nephropathy. So how do you tell the difference?
Okay. This one? Okay.
Yes.
Okay. Yeah, we will deal with myeloma cast nephropathy later on, but some of the morphological features, let me explain, which will help you. This is not PS negative or pale. It is occupying the entire tubule, but this is not PAS pale or negative. This is still showing you PAS positivity. This is PAS positive. And you don't see any cellular reaction around it. And this is not very rigid. In a myeloma cast, the casts are very rigid, almost like forming like a well-defined boundaries, like a fractured. By that, it means this fracturing which you are seeing is because of the cutting. Because the consistency of this cast is different. So when you cut that on a microtome with a knife, you will see that chatter, like a chatter.
Do you have a myeloma cast in your collection next to you?
Not. I don't have a myeloma cast slide right now, cast nephropathy slide right now.
I mean, I think for me as a non-pathologist, I'm like thinking myeloma from that. And like, look at the far left-hand side. There's like, looks like there's a really good crack there.
Yeah.
I don't know.
I think for me, what helps is the PAS pale, and here it's clearly PAS positive.
Yes, and context is important, right?
So they're not quite as pink.
Yeah.
Is that what you're saying?
Yeah, for myeloma, the fractured cast should be pale under PAS stain.
Yeah. But it's not that you cannot see collapsing with myeloma cast nephropathy. But this, and again, if you're really confused, like in this case,
just want to confuse us just a little bit more, Shree.
Huh? You
want to confuse us just a little bit more.
Yeah, that's important, right? Because otherwise, why will you come back to me?
Exactly.
If I'm sitting alone, suppose you are practicing alone and you have no clue what I'm going to do this morphology, I'm really confused. Fortunately, in kidney pathology, there are a lot of tools. I'm going to go back to immunofluorescence. In a myeloma, you should see restriction, kappa lambda restriction, right? Either kappa will be positive or lambda will be positive. In this case, you're not going to see that. This case is going to stain both for kappa and lambda, okay? So that will help you out. Even if you're alone and you're getting confused with morphology, immunofluorescence is going to help you out. So in kidney pathology, you have got multiple friends who are going to help you out. Okay?
Sure, just want to let you know we have about 7 minutes left.
Okay.
Oh man, I feel like we just got started.
Yeah, kidney pathology is beautiful, man. So,
I mean, sometimes you feel like I can't, like these are such beautiful gloms, I can't leave the office today. No. Oh, look at that.
So most of
First off, remember always, what stain are we looking at here? And
so
that,
I would,
nice silver stain.
This is the silver stain. So now, like most of the fellows, they're accustomed of looking at this image when they think of collapsing, because the tuft is collapsed. There's completely.
And where did it go? And is it all just inside there? Like
it's all there. It's just
there.
Yeah,
it's like a balloon just popped
holding up
inside
the architecture. There. It's completely collapsed, gone, and you see the proliferation of the overlying epithelial cells. And over here, you can see even the mitotic figure. Okay, so this is collapse. One of the most common confusion, what I see, like when the fellows start, how will I differentiate this with a crescent is the most common thing I have seen. So in a crescent, it is going to disrupt the GBM also. In this one, this stuff is appearing separate because of the sectioning, but I don't see GBM rupture, and I don't see fibrinoid necrosis. Even the Bowman's capsule is intact, okay? Like over here, I can see this Bowman's capsule is completely circling. It's not damaging. If this was a crescent, I would have seen fibrinoid necrosis, I would have seen GBM rupture or Bowman's capsule rupture. I'm not seeing that. These are all round things, are protein resorption droplets. This round thing will help you out. These are all protein resorption droplets, and you are seeing implosion. The glomerular thing is collapsed, like completely collapsed, okay? So this is a classical morphology of a collapsing glomerulopathy, and this is an intact glom. So this is just an intact glom next to it. So Samira, we are going good on time. So we ended up covering FSGS, NOS, all the variant perihilar. We ended up covering collapsing, tip. Let me do the last variant of FSGS, which is known as the cellular variant of FSGS. So this will be the end, like last variant of FSGS. So in this one variant, we know this is segmental sclerosis because I'm seeing the obliteration of the glomerular tuft, and I'm seeing a lot of cells. I'm seeing epithelial cells, proliferation, I'm seeing a lot of foam cells, I'm seeing podocytes and all that. I cannot classify this into a particular variant. And that's why, and it is very cellular, that's why I'm going to call it as a cellular variant of FSGS. So this Columbia classification, like collapsing, is
there's a question before you go into Columbia classification, maybe just very briefly.
Sure.
Is it helpful? Is it still helpful? Do we need to rethink FSGS? Are we getting to the point where we need to, or is it still helpful?
Yeah, so there is always a path, right? So we started with Columbia classification. Is it still helpful? Yes, collapsing is going to, that morphology collapsing ends up conveying most of the time a worse prognosis. When you're talking about tip, that conveys a very good prognosis. So those two morphological variants are very helpful. So if I have a fellow, I have to remember two variants. I will say tip, I will remember. Nephrotic syndrome, good prognosis. Collapsing on the other end of the spectrum, nephrotic syndrome, worse prognosis. Everything
those two right there, you need to nail those.
Yes, those two you have to. Tip and collapsing, you have to.
Also for collapsing, it can help you with your differential diagnosis and potentially thinking about viral etiologies.
Absolutely right. Yes, viral etiologies, ApoL1 is big. So ApoL1, viral etiologies, medications also. So one thing as a fellow, I should know that is morphology is not indicative of pathogenesis. That is the second step. So morphology is not everything. If I see a collapsing lesion on a biopsy, still I have to go back to my patient to find out what is the reason for that collapse.
Shree.
Yeah, go ahead.
No, I was just going to jump in regarding that question, 30 seconds. So Columbia is important because that's the first step. Like we cannot study diseases if we don't know what they look like. So first we define lesions, and that's what Columbia does. It defines the lesions. But then that's just the next step. The next step is to go into etiology because that is the ultimate where we want to go. But in order to get to etiology, we need to understand the morphology, and Columbia helps you with that, but it's not the ultimate answer.
Yeah, I agree. And understanding FSGS will be very important because as more and more clinical trials are coming, so to classify or to categorize patients in the best possible way about what we know now.
That's one thing we haven't really stressed is that this is not a disease. This is a pathologic description of multiple diseases. And I think that's where I'm trying to get at is how can we get to a point where we can find out exactly, you know, where are some discrete diseases that can have clinical trials?
Mm-hmm. I agree.
All right, so we're just at the top of the hour here. I think we can wrap things up. Thank you everyone for spending some of your Saturday with us today for all the excellent questions. Thank you to Dr. Sharma. That was really outstanding, and really looking forward to our session next month.
Let me post in the chat the Google the YouTube channel.
Yes, I will do that right now.
Yeah, so all these are recorded and put in the YouTube channel for Arkana Live. Please go to that and pass it around. Give us some suggestions. Really what we want to do is have a live session where we actually go over the slides and have nephropathologists and nephrologists all in the same room to demystify pathology and give everyone opportunity to really take a look at this from an insider's point of view. And Samira just posted the link. We'll have it posted soon. So thanks everyone so much. Enjoy the rest of your Saturday.
Thanks a lot.
Have a good weekend. Stay safe.
Thank you. Bye-bye.
Bye.